Myself and Yasmin Nicholas Sakai, Global News Editor for Medical News Today, will be looking at prediabetes and finding out whether it can be reversed. Hi Yaz, how are you?
Not bad, Hilary. How are you?
Not bad either. I'm really looking forward to finding out more about prediabetes today. It sounds sort of innocuous, doesn't it? Prediabetes, like not an illness. But did you know that 1 in 2 people with prediabetes will become diabetic within 10 years?
That's high. But yeah, I found out that 38% of adults in the United States have diabetes and a similar proportion in the UK as well. In fact, nearly half of people don't know that they have it.
And that means that even more people will have prediabetes. So what are you most interested in finding out in our conversation today?
Well, I want to know who is most at risk of prediabetes and who needs to be checking this out.
Yeah, good questions. And as usual, I want to know what's happening within the body. How does a slightly raised blood glucose, like not diabetes, but prediabetes, how can that cause microvascular complications? You know, the damage that high sugar levels cause to small vessels in the eye, kidney and nerves, even sometimes before a diagnosis of type 2 diabetes. And I also want to know how much of these complications related to sugar spikes. You know, when you get a big rise in sugar after a meal and then a sleepy slump afterwards.
And of course, we want to know what we can do about it.
Exactly. Is it just losing fat or adipose tissue, or are there other lifestyle changes we should make? These are all questions we'll be discussing with our guests. So let's meet them. Joining us in conversation are...
I'm Dr. Tom Barber. I'm an associate professor and a consultant endocrinologist. I'm based at the University of Warwick in the UK, and my research focuses primarily on obesity, diabetes, and metabolism.
My name is Angela Chow. I am the managing editor of the global news team at Healthline Media, which includes Medical News Today. I have been a journalist for over a decade. I'm a guest here today because I was diagnosed with prediabetes about 5 years ago, and I was able to successfully reverse it.
Fantastic. Oh, we can't wait to hear about that. So my opening question needs to be about what is prediabetes. But before we start, we need to understand just a little bit about the units of measurement of blood glucose.
Yes, of course. Well, it is a bit confusing because, as you say, there are different units, but essentially in the UK, we use millimoles per litre for glucose, and in the US, it's milligrams per decilitre. To add to the confusion, there's also the hemoglobin A1C, which also has 2 separate units in terms of percentage, which is what we always traditionally used, which has been superseded by millimoles per mole. Millimoles per mole is what we tend to use clinically now and have done now for some years. But you're right, it is a bit confusing, and certainly having different units doesn't help with understanding the definitions.
Are there differences in how prediabetes is defined? I know that there are some diagnostic thresholds. Could you maybe tell us more about them, Dr. Tom?
Yeah, absolutely. Different societies and esteemed groups have different definitions. And I think the first point to make really is that whether we're talking about diabetes or prediabetes, is that we're talking about a continuum. There's been a general trend over the years for the cut-off levels to actually have gone down. Some years ago, WHO endorsed the usage of hemoglobin A1C.
So hemoglobin A1C or HbA1c, that's a blood test which measures the amount of blood sugar attached to the hemoglobin in your blood. And it essentially provides a guide for how high sugar has been for approximately the 3 months prior to the test. HbA1c is the most clear guide as to whether someone has continually high blood sugar or, in fact, has diabetes.
That's right. Although it should be said that A1C does have its limitations and drawbacks, and there are certain scenarios in which we shouldn't rely on an A1C, and actually additional glucose readings can sometimes be helpful as well. In terms of prediabetes, this is based on an A1C of between 39 up to 47 millimoles per mole, and 39 is equivalent to an A1C of 5.7%. I think for the purposes of our discussion, it's reasonable to use those criteria.
Yeah. Angela, when you were diagnosed 5 years ago, what was the cutoff then?
It sounds just around the range that Dr. Barber just mentioned. It was 5.7 and above. was considered pre-diabetes, and the A1C levels that I was tested at was 5.8%.
And I think back 5 years ago, tell me if I'm wrong, in the UK, that wouldn't have hit the threshold for pre-diabetes, Tom. Is that right?
Yes, indeed. So, as I said earlier, the thresholds have gradually gone down in recent times. And yes, you're right. A level of 6 millimoles per litre to define prediabetes used to be used. And Angela, it sounds like your reading was very close to normal.
Exactly. It was so low on the spectrum. I don't even think my primary doctor at the time even had a conversation about this with me, other than just giving me the range and the diagnosis and let me know that this is happening. And something interesting to add is that threshold change, actually in conversations with different physicians and friends who are doctors, some would appear very concerned if you're in that range, and others would just be like, this is not even close to the range that you would need to worry about. So it's very interesting.
So going back 5 years, or sort of at the point you started to kind of be a bit more concerned about it, was probably about 3 years ago, wasn't it? Did you have any symptoms, any thirst, frequently going to the loo, getting up at night to pee, sugar spikes or crashes of energy levels? Was there anything you picked up then?
I definitely didn't have a wide range of symptoms. However, something I did notice is throughout my 20s and late 20s or even early 30s, right before the diagnosis, I would say a lot of times I would feel low blood sugar levels quite easily if I don't eat for, let's say an extended period of time, then I can definitely physically feel it. Whereas now, and we'll talk about this in details obviously later, but after I've done some lifestyle changes and all that, and after I reversed it, I don't quite feel that fluctuation in my blood sugar levels. I feel quite stable. I can fast for 16, even 20 hours sometimes without any trouble.
Tom, is that something that is a precursor to diabetes, these sugar spikes and crashes?
Well, prediabetes is an umbrella term, and it can either include, elevated fasting glucose and or elevated postprandial glucose. And essentially, in the context of insulin resistance, so when the insulin isn't as effective, but also when the beta cells start to decline, that's the cells in the pancreas which release insulin, that is underlying the pathogenesis of dysglycemia, which prediabetes and diabetes. And so, it's not uncommon to have some swings in glycemia, because if the beta cells can't produce enough insulin, for example, or the insulin's not as effective after a meal, then of course the outcome of that is the glucose levels to rise a bit higher than what they should do. And I'm interested in what Angela says, in that she could actually be aware of those swings in glycemia, which is very interesting. Many patients aren't that aware of their underlying glucose readings. At least in the UK, most patients do not monitor their glucose in the context of prediabetes. And I think, again, coming back to what Angela was saying, it's entirely predictable that with improved lifestyle, weight loss, and reversing prediabetes, that you would find that glucose levels become more stable, because the insulin becomes more effective. It's able to deal with the swings in glycemia better. And so you would definitely predict a more stable glucose profile, in addition to overall improvement of the glucose readings, which I think is exactly what Angela describes.
So, Angela, you were saying you talked to different physicians, and some said, oh, don't worry about it. And some said, oh, you need to really worry about it. So do you think there's an issue of over-medicalising some of this? How do you feel? Where do you sit now in your concern about it?
The view I take is that it's something I see as very important to be aware of. However, this is not something that keeps me up at night. However, I think it should be a motivation. From my perspective, when I got the diagnosis, it was definitely a wake-up call. You need to increase your exercise level. You need to do some changes to your lifestyle to get back to a healthier range, whether, the threshold has changed or not. I knew that was something I had to do.
Yeah. It's 1 in 3 people in the US and in the UK who now are diagnosed with prediabetes. So, Tom, where do you sit on the spectrum of concern about the prediabetic state?
I think, if you have prediabetes, you can delay or even prevent the onset of type 2 diabetes. It's called prediabetes for a reason, because many people with prediabetes eventually go on to develop type 2 diabetes. It's essentially a forerunner. Not in everyone, but in many people that is the case. And we know that from studies like diabetes prevention program, for example, we know that intensive lifestyle treatment, like with focus on diet, physical activity, weight loss, and so on, can really help in preventing or at least delaying onset of type 2 diabetes. If you can prevent at least some people from developing type 2 diabetes by identifying prediabetes, then in my mind, that's a good thing. Now, I accept that not everyone is able to implement an intensive lifestyle program, but I think at the very least, it's an early warning signal which alerts people to the need for a change in lifestyle. And if it does that, if it motivates people to change lifestyle, then that has to be a good thing.
Okay, so that's interesting. You see it as a warning sign. In preparation for this, two things that surprised me. One was that there's a 50% chance of diabetes in 10 years if you're pre-diabetic, and that seems a bit high to me. That's like, 1 in 2 people. And then the other thing that I noticed was that these microvascular complications of type 2 diabetes, so eyes and kidneys. So if you do become diabetic, you're the 1 in 2, you're more likely to already have those problems, those microvascular problems.
Yeah, so there have been some interesting studies reported on exactly that topic. And I believe there was a systematic review published quite recently on one of the microvascular problems, which is neuropathy, which is a problem in the nerve cells, which can lead to numbness, tingling and pain, for example, in the hands and feet most typically. And indeed, that study did show that over time, people who are diagnosed with prediabetes can go on to develop neuropathy, even without, the development of type 2 diabetes. And it kind of comes back to the point I was making earlier that, glucose is on a continuum, and we're just essentially drawing a line in the sand in terms of saying, is this diabetes? Is this pre-diabetes? The bottom line is that if your glucose levels is elevated, regardless of how much, that can have adverse effects on cell function, and it can lead to microvascular problems and also to a degree macrovascular problems as well. Now, with these things, time is always important, and the longer that you have this, the more likely you are to develop longer term problems. And typically we're talking about years or even decades before these can develop. So it's not something that happens overnight. But remember, many people who are diagnosed with prediabetes may have had it for a long time, months, possibly even years. It's often asymptomatic. And unless people are actually tested for it, it can very easily go unnoticed.
Yes.
Given how important it is then to know that you are pre-diabetic, since it seems to be a high-risk state, who is most at risk of pre-diabetes?
Yeah, so the first criterion to mention, you won't be surprised at this, it would obviously be weight or BMI, body weight. And of course, the higher that is, the more at risk you are. So as you progress through overweight and obese ranges, that increases the risk. Also, the older we get, the more at risk we become. And the reason for that is that as we age, insulin becomes slightly less effective at its receptor, and also the beta cells can not function quite as well as we get older as well. Importantly, also lifestyle factors as well. So physical activity is hugely important. We know that being sedentary can worsen the risk of insulin resistance, which is a risk factor for prediabetes and type 2 diabetes. And then things like stress, that can also increase the risk. And diet as well, as I'm sure you won't be surprised to hear, high glycemic foods, sugary drinks and so on are going to increase the risk. So we should be trying to restrict our carbohydrate intake as much as possible. But I think it's also worth mentioning here, what's really important actually is ethnic origin. And in fact, I quite recently published a study in over 1.4 million people within the population in England. And we looked at the comparison for a BMI of 30 in the population. And what we found was that in the South Asian group, for example, their risk equivalent for developing type 2 diabetes, which was risk equivalent to a BMI of 30 in white population, was actually 23.4, which is much lower than what the UK medical guidelines recommend, which is 27.5 for a definition of obesity for the South Asian population.
So, Angela, of those risk factors, are there any you prepared to share with us that apply to you?
I would definitely say the sedentary lifestyle behavior. And it's very important to point out that my case might be very different from other people who might be experiencing prediabetes or have other risk factors. I'm very slim and my BMI is quite low and in a very athletic range, in fact. And most people look at me and they would say, there's no way you would have prediabetes or type 2 diabetes. However, my father's side has a little bit of a family history with type 2 diabetes. We're talking about all slim people, no weight issues. So losing weight actually for me personally would not be a healthy thing to do. It was more of a sedentary lifestyle behavior. I definitely was not regularly exercising. I was working very high stress, high demanding journalism jobs, breaking news, a lot of field traveling, covering disasters, you name it. So it was definitely a stressful lifestyle and not a lot of active, healthy diet and physical activities that were involved on a regular basis. So even though I looked very healthy and generally very healthy, to be honest, but I knew deep down that I was not living a healthy lifestyle. And when you're stressed and working long hours, sometimes the last thing you want to do is go exercise. So a lot of times you choose something that is very easy, not necessarily the best thing for you to do. So I think that was the place I started at.
I think Angela raises some really, really important points. And it was remiss of me, wasn't it, earlier when you were asking me about risk factors, I didn't mention genetics, and I should have done, because at the end of the day, type 2 diabetes and prediabetes for that matter is a genetic condition. And I think this is something which we sometimes forget. And I have to say, I don't think the media help with this, because if the media portray it a little bit like a lifestyle choice and relating to obesity and so on, that often when type 2 diabetes is on the media, that's the kind of the impression, and it's rarely talked about actually in terms of being genetic, but it is a genetic condition. And in fact, it's actually more of a genetic condition than type 1 diabetes, which is the other main form of diabetes, and it does tend to run in families. And Angela's case is a great example of that. And when there's a strong family history, you don't have to be the classic phenotype of type 2 diabetes, obese, middle-aged male with a large abdomen, and that notion that we all kind of have in our heads of a typical person who has type 2 diabetes. There's been, I think, over 40 gene mutations identified which can put you at risk of type 2 diabetes. And the other point I was going to make, again, really, when we talk about exercise, most people think about going on a treadmill and doing a 5K run or whatever, getting in a sweat, which, is good exercise. But actually the message should be avoidance of sedentariness. Okay. And sedentariness by definition is any activity either when you're sitting or lying, obviously apart from sleep. Okay. So that's basically a sedentary activity. And so just by standing up, you can be non-sedentary. Okay. We know that when you're standing, you actually burn more calories. It's actually better for health. If you're walking around, that's even better. And there's been some fascinating studies which have looked at changing sedentary behavior, like getting up every hour, every half an hour, and just walking around for a couple of minutes and doing squats in the corner of the room. They show that just that activity during the course of a day can have transformative effects on glucose levels, really transformative effects compared to being sedentary all day. So you don't have to climb Mount Everest. You don't have to even go on the treadmill. So I think Angela's points are really well made.
So the basic issue about prediabetes is insulin resistance. Now, why is that occurring? Is it fat cells causing that? And if so, how do they cause the problem? And how does that happen then in someone like Angela, who, for all we know, didn't have any extra adiposity?
So as you can probably imagine, Hilary, it's very complex. And even with all the data that we have, we still don't fully understand the pathogenesis of type 2 diabetes and prediabetes. And we could talk all day on this topic. But in essence, there's two main mechanisms at play. One is that the cells in the muscles, the adipose tissue, the liver, become less sensitive to the effects of insulin, so-called insulin resistance. And insulin's the main anabolic hormone. It's there to enable the cells to take up glucose. And so it essentially maintains blood glucose levels. And when the insulin isn't working as effectively, then blood glucose levels start to rise.
So it's something happening in the muscle tissue and the fat.
It's to do with the actual insulin receptor, which sits on the surface of cells within the muscle and within the fat and within the liver. And there's certain chemicals in the blood called adipokines, which are chemicals that are released from adipose tissue, which directly affect the insulin receptor and can make it more resistant to the effect of insulin. And you won't be surprised to hear that the nasty adipokines mainly come from visceral fat, which is the fat around the abdomen, which is what I was saying earlier in terms of the risk factors there. So that's one of the reasons why visceral fat is problematic. But the other reason is that the visceral fat drains straight into the portal vein, which goes straight into the liver. And so the liver becomes bombarded with fatty acids that are released from the visceral fat. And that can lead to something called fatty liver, which can impact on insulin sensitivity within the liver. But also, in addition to that, you get overspill of fat from the liver into the systemic circulation, and then you get what's called ectopic fat deposition within muscles, for example, around the heart, and that can directly worsen insulin sensitivity as well.
So it's an interplay between the lipids and the glucose. So it's not just glucose and the pancreas and insulin.
That's right. I mean, there's literally hundreds of factors implicated here. And the other thing to say about type 2 diabetes is it is actually a chronic inflammatory condition. So you have kind of low-grade inflammatory process in the background, which is going on, for example, within the fat tissue. And that is quite low-grade, can also impair the sensitivity of the insulin receptor. And then what happens is that the beta cells themselves, the cells within the pancreas which release insulin, in some people, they start to decline. So you can imagine when you have resistance to the effect of insulin, the beta cells have to work harder to produce more insulin to overcome that resistance. It's like trying to flog a dead horse. You're constantly trying to make more insulin to counteract the insulin resistance. And in some people, that's fine, okay? Regardless of their insulin resistance, they can produce enough insulin to counteract that and their glucose levels remain normal. In fact, in the majority of people, that is the case because most people don't develop type 2 diabetes, even with a BMI of 50. But in some people, the beta cells are not able to keep up and eventually they give in. And then there's a relentless decline in beta cell function and insulin levels drop and glucose levels increase commensurately with the drop in insulin release. So in essence, that is what's going on. As I said, it's much more complex than that. There's many more elements to it, like kidney excretion of glucose as well. The other thing that's very topical nowadays is the role of the gut as well, the microbiota, and the interplay of that with the peripheral inflammatory processes and insulin sensitivity. We know that eating a healthy and varied diet, which is plant-based, fiber-based, and so on, will help to reduce that inflammatory process and to improve insulin sensitivity.
Angela.
It's very interesting that there's that insulin resistance and mechanisms happening in the muscle. Is it possible that the reason why exercise and physical activities are so effective as a way to maybe mitigate some of these issues and help people to maybe better prevent prediabetes or type 2 diabetes is because physical activity is able to maybe target some of those problems that you just mentioned that happens within the muscle cells?
Yeah, absolutely. So there's literally hundreds of potential mechanisms whereby exercise and physical activity can mediate a beneficial cardiometabolic effect. But also, when we exercise, we release something called myokines, which is certain chemicals that are released from the muscle. And just as with the adipokines, some of those causing insulin resistance, some of the myokines can actually improve insulin sensitivity. So the actual act of exercising and the release of these myokines can mediate some of those cardiometabolic benefits. The other thing with physical activity is particularly the resistance training, is that you can improve your muscle mass, which is very helpful because we know that just by having a greater muscle mass, you can actually improve your overall metabolic rate and thereby help to maintain body weight, and that will help with any kind of strategy to lose weight as well. But also when you're exercising, you're oxidizing fat, you're burning fat tissue, you're using that in your muscles, and that will all help as well. So it's the combination of all of those things really which leads to kind of overall metabolic improvements. And I think a key message that I don't think is really out there is that even if you exercise and you don't lose weight, and incidentally, most people who exercise don't in fact lose weight, it doesn't mean to say that it's a waste of time. It's an incredibly beneficial activity to do for your health, and we should be encouraging people to avoid sedentariness, not for the purpose of weight loss, but just because it's a healthy thing to do.
So, Angela, you've maintained your HbA1c levels within a normal range for 5 years now.
Yes.
Can you tell us how you did it?
Absolutely. So, one, I started changing my diet quite a bit. To give our listeners an example, I was eating a lot of white rice, but now if I want to consume carbohydrate, I might do rice combined with quinoa or farro or sweet potatoes. So those are the little changes I made to my diet on a regular basis. I was already eating a lot of veggies and fiber and fruits, so that was never an issue for me to incorporate in my diet. But it was mainly not drastically reducing the amount of carbohydrate I was eating, but rather, choosing healthier options that I think would benefit me in the long term. And that was very hard to do. I'm not going to sugarcoat it. So one takeaway I got from that is to generally give myself a little grace. Same with exercise. Think about this as this is not sort of, like a 2-week thing I'm going to do, and then it's going to produce this enormous result. It's more of, I'm not going to cut out any food that gives me joy. However, I'm going to reduce the amount I'm eating. The foods that might cause me long-term problems or are not getting me where I need to be with my health goals, I will just eat it once a week versus 3-4 times a week. And that was sustainable for me. I still eat every single thing that gives me joy because I'm a foodie. I love food. There's no way I can cut out noodles and rice in the long run. So that was one thing I did.
So you slightly tweaked your diet. That's the first thing you did. But what else did you do?
The second thing that I did that really helped me, what Dr. Barber mentioned earlier, was physical activity and exercise, and specifically resistance training. So I would probably do 3 times a week. Each session would be like 30 minutes, most of the time on my own, following a specific set of exercises and movements. And that would involve squats, which Dr. Barber mentioned earlier, body weight movements, and also using weights, gradually increase the weights I was using. So that was huge. That was a big change.
How long was it before you saw results, Angela?
Obviously, reversing my A1C was a goal, but it actually took me about 2 years before I was able to get it down to 5.4% from 5.8. So to a lot of people during that 2-year period, and myself included, it was not very encouraging sometimes when you're not seeing immediate results. But I think having that mindset of knowing, hey, it didn't go up. So that was good, right? I was onto something and I just kept going. And I haven't had issue ever since I was able to reverse it.
Dr. Tom, is that length of time, is that normal to take that amount of time to get just down into the normal range?
It varies quite a lot. We know from studies that we don't all respond to the same changes in diet equally. Different people respond in different ways, and there's lots of different factors that can impact on your response to dietary change. And by that, I mean primarily in terms of weight loss. But I think, of course, coming back to what we were discussing earlier about genetic factors, it's a cruel fact to say that some people just simply find it harder to improve A1C, to get weight down because of their genetic endowment. So if you're unlucky enough to have inherited predisposition genes for type 2 diabetes, then you have to work harder to actually get results and for longer. Likewise, certain ethnic groups automatically predisposed to being more likely to develop type 2 diabetes at any given BMI. And so therefore we'll often find it harder to reverse that. But I think coming back to the point we made, even when the dice are loaded against you, there's still a lot you can do. And as evidenced by Angela, she said that her weight wasn't particularly high. She had a very strong family history. It wasn't like she could just go and lose loads of weight. That would have been clearly wrong, and it would have been actually harmful potentially if her weight went underweight. But she changed her lifestyle in a way which improved her insulin sensitivity, particularly with the physical activity. But yeah, the key take-home message is that regardless of what your setup is and what your scenario is, there are elements of type 2 diabetes and prediabetes which are reversible. It's not going to be easy in every person, but it is ultimately reversible.
So Angela's dealt with it in a particular way because she didn't need to lose weight. Can we just now focus on people who do need to lose weight? Because if you do have central obesity, you do need to get rid of that. So do you mind if we just do like a quick fire round of some things that come up often on losing weight, ways to do it? Low carb.
Yeah, I definitely would advocate that, yeah.
Keto.
It's kind of a variant of low carb. I think I would focus on low carb rather than keto particularly.
And Angela, you were a no on keto as well?
Yeah, I never did keto. I did a lot of digging into what it involves, and I have a lot of friends who did it. However, I do not use that. I will say that I did reduce my carb intake, not significantly, but maybe by like a 5%.
Intermittent fasting.
Interesting one. There isn't a huge database on this, but it certainly works for some people, and it does seem to replicate what we kind of evolved to be. And by that I mean going for periods of fasting and feasting. Didn't evolve to have 3 meals a day. So it's probably good in the sense that it gives the liver a bit of a rest every now and then.
Angela, did you try it?
I am a believer in intermittent fasting. I'll be honest. I do this regularly, and I do a very modified version. By that, I mean, I do eat breakfast some days, and I just try to keep at least like a 14-hour window where I don't eat on most days. And from my perspective, again, this might not work for everyone, as Dr. Barber mentioned. For me, it worked wonders. Intermittent fasting is a way to say, I'm only eating 2 meals a day. So there's a longer window I'm not eating. So I'm naturally not able to pack in as much of the same kind of food within, those 2 meals. And I was not cutting out calories. So I was eating a healthy amount of calorie intake, just eating fewer times a day.
Okay. What about bariatric surgery?
Well, I mean, of all of the weight loss strategies we have, that is the best option in many cases. Unfortunately, it's also woefully underfunded, certainly in the UK.
And the GLP-1 agonist Ozempic?
Yeah, well, obviously very topical right now. And of course, we have Wegovy, which is the same molecule, semaglutide at a higher dose, which is licensed for obesity. And, there's some excellent data to say that you can get weight loss into double digits, which is an excellent outcome with this drug. It inhibits appetite directly, but it also slows down emptying from the stomach. So it can have indirect effects on appetite and also glucose control. But yes, as a treatment option, I think it's excellent. A couple of downsides. Firstly, it's injectable therapy. There is an oral version, incidentally, in the form of Ribelsis, but it is most GLP-1s are injectable. And the second major important downside is that it only lasts as long as you take the drug. Once you stop the GLP-1, the weight typically goes back up within a matter of weeks. And that is an important point to make. And I guess the third thing is that in some patients, this class of drug can cause nausea, a bit of vomiting, and occasionally can be intolerable. But most patients can tolerate them generally okay.
And making breakfast a protein and veg meal rather than a carb meal.
So I think there's quite a lot of data out there about what influences glucose spikes, and certainly time of day is relevant. Eating earlier in the day is generally better. Avoiding high glycemic foods on their own, but combining with high fiber foods will help to slow down the absorption of glucose. There's even some evidence, for example, vinegar.
That was going to be the next one. Vinegar. What about vinegar?
Yeah. Well, it can slow down gastric emptying, but also can have some effects, some peripheral effects as well in terms of glucose uptake. So vinegar, there is actually some evidence to suggest that vinegar can help with stabilizing out glucose spikes. But really the main message really in that regard is to limit glucose and sugar intake and restrict carbohydrates, particularly high glycemic carbohydrates. That's the best way to kind of avoid or limit the glucose spikes.
Are there any final take-home messages that any of you want to make?
One big takeaway is just the awareness of doing something is better than doing nothing. No matter what your risk factors are, no matter where you are starting today, I think that is my biggest takeaway from my personal journey. And the other takeaway is give yourself some grace. It takes time and it takes the right strategy to be able to sustain certain changes that will make a great impact on your life in the long run. So I think that would be my 2 biggest takeaways.
Dr. Tom Barber, Angela Chow, thank you very much. That was so interesting.
Thank you.
Thank you.
And Yaz, Thank you very much for investigating all that with me.
Thank you. I learned a lot.
And thank you for listening. You can read Yaz's feature on reversing prediabetes at medicalnewstoday.com. We'll be back next month to discuss Parkinson's disease. I'm Dr. Hilary Geit, and this is a High Vis Radio production for Medical News Today.